So the first question I have, Jan, titanium versus stainless steel. Which do you prefer and why? And do you feel that there's much of a difference between the two in your opinion?
Short answer is no. I I don't think there's a difference really in terms of healing and everything. I think most people have gone towards titanium now. It's a little bit more you can contour it better in the foot because it's just it's a softer metal. But I don't think, since we're not really looking for strength in the foot, except for Charcot patients, it makes that much of a difference, stainless versus titanium.
So what do you usually use?
I usually use titanium because the manufacturer that I use, or the company that I use, it makes all titanium. But I have nothing against stainless steel in the foot.
How about in the ankle? Difference in the ankle versus foot?
No, you know, I think just in terms of like just contouring, plate contour, I think I like titanium better from that standpoint. But I have not, I don't think it makes that much difference for the most common applications that we use it for. What it's like a regular ankle fracture. We're using like a 1/3 tubular plate or so forth. I don't think it matters whether you use titanium or stainless in that type of case.
Okay. What about applications outside foot and ankle? Since you do some trauma, any difference there?
It's usually based on the manufacturer, because some places, some companies don't make a lot. They make more titanium, only titanium or steel and titanium. If I want something more rigid, if I'm dealing, then I'm using something more stainless steel, I'll prefer. But otherwise, I'm fine with titanium. I really don't think there's that much a difference anymore. And then somebody asked, what about peak carbon fiber? I'm actually a fan of carbon fiber, and Peak as well. One of the companies I use does do it. It uses Peak and titanium actually. And so I'm a fan of that. I think there's some benefits in terms of imaging that was asked in the chat box. That maybe when you're getting CT scans, especially for fusions and so forth, I think that makes more sense. And I think some of these other materials are very interesting for their fatigue strength as well as for imaging characteristics.
So there was one, thought that for titanium, you mentioned this before, you find that titanium's a little bit easier to contour?
Yes.
Okay. So it's interesting because I'm almost the opposite. I do use quite a bit of titanium, but my preference in a lot of situations is to use stainless steel. And it probably has to do with having had to take out some hardware and having some strip when it comes to some of this, like the titanium. There's an argument that the modulus of elasticity is a little bit more closer to bone with titanium. Do you think that matters? Do you think that's important, or do you think that's maybe not as important as we like to think?
I think that matters when you're dealing with like long bones. If you're dealing with like nails, for like a female tibia, I think then there's a difference between titanium and stainless for the modulus elasticity.
What about, okay, so let's take a situation of a pilon with bone loss. Do you think that makes a difference then? And you're replating, let's say.
Yeah, I don't think so. I think it's different when you're using intramedullary device versus using a extramedullary, like a plate and screw. I think I actually personally like stainless steel pilon plates, for example.
Yeah, yeah, I do too. I mean, and part of it's just maybe the way I've grown up, but I for a long time I was just absolutely not wanting to use titanium at all. I really like the stainless steel. That may be a little bit backwards. Right. I think now either one's fine. Most of the plating systems for like ankle fractures are going to be stainless steel for me. Partly just because that's what's available and that's what we have. What about, okay, so metal screening, allergy screening, nickel allergy, then what are you doing?
I have never screened a patient for metal allergy.
What if they come in and say, I am allergic to nickel? What do you have that does not have nickel? Are you going to a carbon fiber plate or?
It's interesting. I have never been asked that. I so that's I never even thought about it. I know it's from in the total joint world it comes up. I have
Yeah.
never been asked it in the trauma setting. I mean, I guess because patients don't know what we're going to do to them.
One of the
Many
benefits of being a trauma surgeon.
right. So it's a little too late if they start asking that.
Okay. So then let's say one other. Oh shoot, I had one other question. I want. Oh, okay. Metal mixing. Then, if you have a system that's titanium and a system that's stainless steel, I mean, at one point it was don't use them at all. How are you approaching that? Is that something that you just don't have either? You have one or the other and nothing else on the table, or is it a matter on where you're fixing something? Say like the medial side versus the lateral side.
Yeah, so just like the literature has pointed out that there really is no complication if you mix the metals. I've never thought twice about mixing a metal.
Yeah. Do you worry about it if you are like if you're crossing, like if one screw hits another, or that doesn't bother you?
No, no, no. Man, you're gonna like give me nightmares tonight or something. I've never thought about this before, Nick.
That's my goal, is to give you nightmares. I like this. This is a fun game. All right, we're gonna move on. Any other questions regarding metal components? And if they
Hey, let
come
me
up
ask
at
you, what's your thought about some of these alternative material implants like carbon fiber or peak titanium mixed? Have you used any? Are you in favor of it or?
I haven't gone there yet, and partly probably mostly just because it's pretty hard to get at our particular system. I had one patient who had a history of I think it was giant cell tumor, like in the tendon sheath, and I did an MP fusion, and it was one in which I thought potentially about getting that, like using a carbon fiber option on that.
Yeah.
So that one that's a situation where it may be helpful. I think there's some validity if you're doing like a talus fracture and you kind of try to stick to more titanium implants in that scenario, just to decrease metal artifact if you're following for AVN. But I haven't gotten to a lot of the alternative options yet. And again, maybe it's just because I'm a little bit of a slow adopter. Maybe it's just because I haven't run into the correct situation. And again, part of it is a little bit of a systems issue. How about you?
Yeah, I mean, I've tried them all. I would say, or I mean, I'm not all, but I've tried them because I think some of it's interesting to me from like a fatigue standpoint. But yeah, I'm not a huge fan of just the carbon fiber implants purely because you can't really contour them and it's very brittle. If you crack a carbon
Yeah,
fiber
I
plate,
could see that.
it's done. You're where like titanium, stainless steel, or peak in titanium, you can contour it around the foot or ankle fairly easily. But carbon fiber is, I think, for nails or something like that. I think there is some from their fatigue strength. It's very interesting, material. I think that can be used.
Yeah. Okay. What about nitinol then? I mean, how does that factor into things for you? Is that just a completely separate
That's
situation?
separate because I've not seen any plate. I know some people are now coming out with some screws or
Yep.
the constant compression. I think that's very interesting as well. There's different nails. I mean, they even make a sub-talar nail now.
Yep.
And so I think some of those constant compression, I know there's some competitors on the market working on devices that are going to be, I guess, similar to nitinol in terms of the constant compression, but use a different, I don't know if they're using a different metal because nitinol is fairly expensive.
Yep.
And I think that is why it's been slow to adopt, just the cost of it.
Yep. Yep. Okay. Let's talk about screws now, specific screws, locking versus non-locking. How do you build your plate constructs? What are the advantages and disadvantages of either option?
Yeah, that's a great question. Whoever had that. So I think with non-locking and locking. So first of all, I think I look at a couple things. One is, do I want do I need to put the plate down to the bone? And if so, you can't do that with a locking screw. You got to have a cortical screw to get the plate closer to the bone, and that's how most of these plates work, is by the friction of the plate to the bone. So you need it pressing against the bone. And then, I don't use, when in terms of locking screws, I use it if someone has poor bone quality or it's a very short segment. And what I mean by short segment is if it's like distal in the fibula or the tibia, where it's just where you're spanning the metaphysis and you don't have a lot of bone, then I will tend to use, I tend more to use locking screws at that point in time. How about you, Nick?
Yeah, I'm very similar, where let's just take a fibula fracture, for example. Kind of my go-to is a locking third tubular plate. And then oftentimes in those two distal screws, I'll use locking screws in that situation. I try to, in terms of the sequence of things, what I try to do is put all my non-locking screws in first, just to get, like you said, get that to compress down to the bone. And then I will put the locking screws at after everything else is in. That's ideal. Now there are a couple situations in which I'll do it maybe a little bit different. One is like if I'm doing a Lisfranc joint, Lisfranc fracture, like a fusion or fixation. Sometimes what I'll do is I'll use the BB tacks to or those threaded ball tip guide pins to get that plate to kind of squeeze down to the bone, and then in the kind of those cuneiform joints or the cuneiform bones, I'll put locking screws in there first, and then I'll try to compress through with like a locking screw or a non-locking screw, sorry, in the shaft of like the second or third metatarsal. Same thing with like an MP fusion. Sometimes I'll go ahead and fix that and I'll lock that distal in the phalanx because that bone's not very good and I don't get very good purchase. And then I'll use the better bone in the shaft, and I'll use a non-locking screw and compress it with that.
No, I think that's a great idea, especially with fusions and so forth. I think it's a nice tip and trick there. Or distal radius fractures, you can do the same thing. Put locking screws distally, and then help with your volar tilt and so forth. The one thing is, I don't know, Nick, is your health system showing you the costs of your cases?
They are, and they're cracking down on, not cracking down, but they're trying to get you to look at it so that if there is stuff that pops up that you're like, oh, I could use something cheaper, that you try to do that. You're right. The locking screws are going to be more expensive. So you try to use them, I don't want to say sparingly, but really only where they're needed. And what I mean by that is, when you're putting screws in the shaft, for example, and the bone is good, I really think I much prefer to use just a standard non-locking screw. I think it's just better. It's better for construct, all that kind of stuff. And so I really try to use them only where I think they're absolutely necessary.
Yeah. I like, in terms of like sharing costs. So it's interesting because it affects what we're doing. Right. And I think that as reps and industry representatives, they need to be aware that we're getting that data now. We've been getting it for a few years, but I think a re-emphasis on it lately, where like I know what my ankle costs compared to my partners.
Yeah, it's crazy. I mean, not crazy. It's probably good, but it also kind of pits you against somebody else. But there's a fine line too between trying to do what you think is right and maybe not a fine line, but you want to do what you think is right as well. You don't want to leave them with just like a standard 1/3 tubular plate and an osteoporotic, diabetic ankle fracture, because you probably need something beefier. But maybe you don't need to use an anatomic locking plate on all fibula fractures.
Correct. And I think that's going to be key. I think we're going to be, as surgeons, and I think that's where I think reps, if they can provide, I wouldn't say, I don't know if cost effective is the right word, but just be transparent with the surgeons, be like, hey, this is a good technique we use, or we can do this, or this is another option to use. It is a little bit, more cost friendly. I think those things are going to be more relevant in discussions with surgeons. And with hospital systems, frankly. I think that's going to be a huge thing, or it has been, and it will continue to be.
Yeah. Okay, this is a great lead into, Colin had a question: opinion on staple versus screw fixation, when and where, and then other than cost. I think you have to factor cost into it, but I think it helps only because I think it helps the discussion. Jan, any thoughts on staple fixation?
Yeah, I'm a fan of staples. I mean, even though I wouldn't say burned by some, but they're not like an end all be all, like just like plates and screws. So I think, for me, I sometimes use them for TMT fusions. If I could, especially like the third TMT, which is smaller, I've gone sometimes just using a staple there. But in terms of cost, the interesting thing is if you're just doing screws versus a staple, the cost is very different. If you're doing a staple versus a plate with screws, and especially if you add in a couple locking screws, that cost is, I mean, very similar. And sometimes the plate and screw contract could potentially even be more if you use, like, say, 4 locking screws versus 1 staple. So it's very, when people say staples are very expensive, I don't, it depends how you're using them and where you're using them. But I think they're very useful tools.
Yeah, I agree wholeheartedly. I think it's a good tool. I would say that you have to be a little bit cautious. There's some reports I've seen, 100% union rates. I've had some people.
I wish
Yeah,
there was
I
100%
wish there
union
was
rates, man.
100%, and there's never 100% in anything. What did one of our peds orthopedists say? Say never, never say always. Do you remember that, Jan?
Yeah.
And I kind of try to keep that same mindset. But what I will say is that the nice thing about staples is they are fast, meaning that when you go to put them in, like especially if you've had a hard midfoot, it probably can save me at least 30 minutes easily. But when you talk about plating and taking the time to put all the screws in, get the plate in the right position, adjust it and fine tune it, whereas the staples, they are fast, and that saves OR time, and that is that can result in real dollars as well. So that's why I said you have to factor cost in a little bit, but I think from both perspectives.
Yes. And I think, they're also less invasive, not necessarily less invasive, but less prominent. So if you don't have to take out screws, I think they're, one thing is I saw a couple papers on it recently where they said not necessarily 100% fusion rate, but some of them are so strong that it looks like it's fused, but the bone is
Yes.
actually not
Yeah,
fused.
it's crazy. It's very mind-boggling. That paper really, I
Yeah.
thought was very interesting. Very
And
interesting.
I think that whole like there's some companies, I've never used it, but it's like a combo. It's like a plate slash staple. So you put screws
Yep.
and staple. And
Mm.
for me, that's actually kind of interesting because I think it's just like just to get as much compression as you can on some fusion sites. I've never tried it, but that's something that I think, like if you said, if you can increase your fusion rate even by 5%, reduce OR time by 15 minutes, it may be worth that extra cost.
Yeah. Yeah, that was an excellent question. Thanks for bringing that up. I had a question here, trying to learn more about lateral ankle stabilization. Seems like we got excited about internal brace type constructs early, but now there's more talk about biologic reconstruction or flexible solutions. What have you been seeing in your practice? I mean, I can talk about this a little bit. I guess I can start it off. I've seen arguments going either way. I will tell you that I probably most often use an internal brace type construct for full disclosure. And the reason, and I've used it for a few years now, and I've had times where there is some technique to it. You can't just put it in and make it as tight as possible. I think there's some technique to it. And there's different arguments I've heard back and forth. I guess I won't belabor you with all those, whether it's you want flexible or whether you want something a little bit more stiff that more closely mimics a ligament. But I think both are good options. I think reinforcement or backing it up with something or augmentation is going to continue to be kind of the standard. That I don't want to say standard of care, but what the most common thing is, and it gives me some confidence that I can move them early on. Whether one is better than the other, I think remains to be seen in terms moving forward. But I think it's a good question. I don't know if I know the answer yet, but certainly worth having a discussion. Jan, any thoughts on this topic?
Yeah, I mean, I don't do as many ankle stabilizations as you do. I do, I don't do that. I do them occasionally. I usually will reserve an internal brace for someone who has like there's some ligamentous laxity at baseline, and or they're like a revision.
Yeah.
I tend not to do it as a primary stabilization, but in these new biologic solutions, I just don't know. I mean, I think some of these biologic solutions will be the answer for many things, like whether it be rotator cuff tears or ankle stabilization. But I don't know if it's not very regulated right now, and that kind of concerns me. And I don't want to offend anybody on this call. I just don't know if we have enough data to be using it many times when we have like good solution with suture. And
Yeah.
that's what concerns me with some of those devices.
It is extremely nice though that we have some revision options, because I mean I could do a whole like dive into what we used to do, where we did perineal tendon, we sacrifice the perineal tendons for revision situations, or if you had deficient lateral ligaments, where you're doing a Crispin Snook or a Watson Jones, like all these different perineal tendon transfers to try to reconstruct the collateral ligaments. It is really nice to have more options, whether it's
Yes,
internal brace or Artelon or BioBrace, or even an allograft. Don't forget that that's been around for a few years. The nice thing is we're getting away from sacrificing the perineal tendons, because those are going to be important towards lateral ankle function or ankle function and range of motion, stability, proprioception, all those kinds of things. And it's really nice to have more options.
I agree.
Here's a question. Are you experiencing delayed soft tissue healing for patients with a history of chronic wounds, DFU, venous ulceration, I'm assuming? Are you using any biologics when closing on these high-risk patients? Why or why not? Jan, what do you think? Let's talk maybe trauma from a wound healing perspective. Like, what are you doing? Any biologics in those situations?
I've played around with it a little bit in the past on some patients. I have not been impressed with, like, once again, there's not a lot of data on it. And I know we can't always wait for data, like, level one randomized controlled studies. We're just never going to have them in some, certain products and surgeries as well. But I think this has definitely there's such variation in not only the use, but how you use it and what is in actually those products, that I have not jumped to it and so forth. I will for bad wounds or something that I'm worried about, whether it be in a trauma situation or elective. I do use things such as like an incisional wound vac. I'm a big fan of incisional wound vacs. I use quite a few of them. Just part of it, I think it helps with blood flow, but also I think it just keeps the wound clean, right? It's a sterile dressing that you put on. The patient can't get it really dirty. You don't have to worry about people changing the wound or changing the dressing and so forth. But I'm not jumped to the biologics. I do think in the future we will have some more data for biologics for wound healing, and I think that will be potentially a game changer in some patients. But right now, I think it's a little too early to tell which ones will work.
Yeah, I am kind of on the same page. I guess I don't manage as many like chronic wounds where you're talking about, using some of these biologic dressings and amniotic products. So I don't know if I'd be in a great situation to comment too much. I think there's a lot out there. Wound care, I struggle a little bit to know what's uh, backed by science and what we're just trying to do to try to help move things along or move that needle along. Um, and it's a tough problem for sure. I totally agree with the wound vac though. I use that quite a bit. So if you have a wound vac device and having those for these high energy injuries or patients that you're a little bit worried about the skin, I think that's a great option.